Good morning. My name's Dr. Karla Blee, and I'm one of the consultants in sexual health and HIV based up in central North Wales. It's a real pleasure to come and talk to you today about my project, making getting treated for sexually transmitted infections easier. What we know is early treatment of STIs is important not only to the individual because it brings about symptom relief and reduces the risk of developing complications, but it's also helpful for public health because it reduces the risk of onward transmission. We already know that STIs disproportionately affect young people, those who are socioeconomically disadvantaged, and those who are often viewed as marginalised or vulnerable because of their life circumstances. And these are also individuals who find it difficult to access services even pre-COVID. Now, we've always had a traditional pathway that if someone is identified as having an STI and requiring medication, they would need to come into clinic to book and collect their medication. Now, pre-COVID, we offered a walk-in service, so you didn't necessarily need to book an appointment. But during COVID times, we had to restructure the service. We'd also put in that we could post a prescription or indeed post the medication directly to the patient. And if, again, this was not possible, we would contact their GP and ask if they would take on the prescribing responsibility. However, during telephone consultations, patients were asking, why can't I just collect it from my local chemist, just like I do my other medication? And that's made us start thinking, is there a better way? So we looked at the current and traditional pathway, and what we found was that over 30% of individuals had to wait 3 or more days to receive their medication. People reporting that we were difficult to get to, and this was certainly compounded in COVID because we had to reduce the number of clinical sites that were operating. People on average were having to travel 9 miles, which would take 15 minutes by car or 56 minutes by public transport. And one patient actually quite sensibly told us there was no way they could get to clinic because it was going to take them nearly 3.5 hours to get there. So for these individuals, they would need to wait for the post to arrive, which could take up to 3 days, and particularly in view of heading up towards Christmas, potentially longer. It was also not great for the service because of how we had to stagger patients coming into clinic to collect their medication. We had to book them an appointment. And if we totaled up all that time, we could see another 4 patients who could not be met outside a specialist healthcare setting. So we started to think in line with our health board's strategy about living healthier and staying well. What we wanted to do was reduce these health inequalities, take care close to home, provide care for more serious healthcare needs that could not be met elsewhere, and reduce system inefficiencies. And so we designed a new pathway that when somebody was identified as requiring medication, we would arrange for a prescription to be digitally sent either by fax, email, and occasionally Hospify to the patient's chosen pharmacy to enable them to collect the medication on the same day. We gave the patient choice, however, that if this was not suitable or appropriate for them, then we would revert to our traditional pathway. What we found was it was very well received by patients, and indeed it reduced on average the distance being travelled by 8 miles, reducing it by 11 minutes by car or 40 minutes by public transport. And so we took care close to home on average, reducing the distance by 75%. It also meant that same day treatment was available to 100% of those individuals who required it. And what was encouraging actually was a fifth of those who opt to collect it from their local chemist would not have been able to have got to our clinical site, which meant they would have had to have waited for the medication to arrive by post. Thinking about creating space for those with more serious healthcare needs, we found in combined time, it would enable us to see 3 patients extra per week. And that would be by our nurse specialists, increasing our capacity to 5 to 8%. And this is particularly important at this point where we have accumulated a waiting list for patients living with warts, and we've now increased our capacity to bring them back into service. It hasn't all been smooth, though. We haven't really reduced our system inefficiencies. This is an incredibly time consuming process, actually. It enables us to get patients directly to the chemist, but to do that, we need to write a prescription, phone the pharmacy, send it to the pharmacy, as I said, by fax, email, or Hospify, then phone the pharmacist again to make sure that they've received it, followed by messaging the patient to say that they can go to the pharmacist to collect it. We've opted now to message the patient rather than try to a repeat phone call to speed this process up. We had hoped that during telephone consultations, if we identified a patient requiring something that they can get over the counter on the common ailment scheme, we'd write the prescription and send it to the chemist so that they wouldn't need to have the full consultation again by the pharmacist. But because of the time consuming nature, that's not been possible. Now, of all the patients who have completed an online feedback, 100% would use this pharmacy collection again, which is encouraging. And a couple of them have provided some comments saying it was very informative and the options were very good, and they found it an easy and valuable service. Following the analysis of that data, we have had a couple of case reports. We had one individual contact us 6 weeks later to say they'd not received treatment, but on speaking to them, actually they had not gone to their community chemist to collect the medication. This did reveal to us, however, that with the restructuring during COVID, we had lost the patient follow up between 3 and 4 weeks after diagnosis to make sure that they had taken their treatment. Of course, if they had been coming into clinic, they would have flagged as a did not attend, and we would have had an earlier opportunity to contact them. In the second case, a patient had gone to the chemist and had not had treatment available because the prescription had not been received. And when we looked back through that case, the protocol had not been followed. So, what are our next steps? As I said, it's an incredibly time consuming process and it is very reliant on someone being able to prescribe at our end. We therefore are expanding the number of prescribers by enrolling our nurses as independent prescribers. That will increase our prescribing capacity by 25%. It is currently only available in Denbighshire and Conway, and so we want to adopt and spread this both to the west and east areas. We need to change culture. We have always had just got patients to come into clinic. So actually outside prescriptions are something that's very unfamiliar to us. And therefore we need to start thinking about prescribing first and then coming into the clinic to collect as a second. It has the potential to expand medications. At the moment, we are really doing it for the acute STIs, but in time, we could expand this to include prevention, such as pre-exposure prophylaxis for HIV. But that will require a huge adjustment in what is available within a community pharmacy. And then about influencing decisions. I'm aware that there's been an independent review for electronic prescribing and electronic transfer in Wales, which was commissioned by the Minister for Health and Social Care, which concluded in April 2021. And I think it's incredibly important that sexual health is viewed as one of the stakeholders within any of those future decisions. And a little bit about my Bevan Exemplar experience. Often when we're trying to bring about change or implement a project, it often feels like we're holding on for dear life and we're getting tired and we're not really certain we're ever going to achieve and get to the summit and get it implemented. What I would say is the Bevan Exemplar experience has been one of huge support. It kind of gives you a safety rope just for you to sit back, take a moment to reflect, reevaluate the situation, and can give you the energy to finish the project and get it implemented. So I'd like to just say thank you very much to everybody involved, all the team and all the patients, and particularly all the staff who've come along on this journey, and to the Bevan Commission for all their help and support.
We will now have a Q&A discussion. Have you thought about spreading this to other health boards?
Absolutely. So, fortunately, in sexual health, we have the British Association for Sexual Health and HIV, and we've got quite a strong Wales branch of that. I've already been in contact with the chair of that, and there's quite a lot of there's a lot of interest in this, and that's going to be a forum that hopefully in the autumn I'll be able to take this to and discuss with actually those in other health boards as well. So I think there is a lot of interest. In some ways, we're fairly fortunate that our service is relatively smaller, so the number of positives is probably less than if you were looking at something like the Cardiff and Vale, where I really feel the value, and I think the changing point where we'll reduce those system inefficiencies is if we get the go ahead from the Welsh government to adopt the digital transfer of
Mm,
prescribing, because all of a sudden this very time consuming process will be speeded up. And I think that has a real benefit to patients. I'm always open to as many ideas. Is there a more efficient way of doing it? Um, I have to say, we've probably found the most efficient is Hospify, but that's not necessarily something that a lot of information governance people would be as comfortable with using. And if not email, faxes, I would say, is probably the thing that slows this entire
mm,
process down. And so trying to get community pharmacies to adopt, and I know NWIS has been working with community pharmacies to use email rather than fax. So I think there are some changes that can help. And I think as that happens, I think those inefficiencies may actually improve. And I think that would then be an easier sell to other health boards. But yes, there's lots of interest. And as I said, in the autumn, when we have our next national meeting, I'm hoping to present this data to them.
What could the Bevan Commission do to help people such as yourself overcome national barriers?
The Bevan Commission have already been sort of helping with that, in helping with providing contacts into kind of the chief pharmacist for Wales, so that we could actually get sexual health and make them aware at that kind of national level that this project has been ongoing. And the plan will be to share actually some of this information up so that they can kind of capture that. And I think that's certainly what the Bevan Commission can continue to help with, and perhaps polish it a little bit more and do a bit more of that in-depth evaluation, so that actually it's as hard hitting as it can be to really make sexual health beyond that. If I'm honest, when I started this project, I wasn't aware that there wasn't a national system for electronic prescribing. So a lot of my career has been in England, where they have the NHS spine, and I just thought that sexual health wasn't engaged with that because we often have very different systems because we don't use NHS numbers. So the project changed a little bit. The focus had to change, and how we were managing it needed to change. But I'm still quite pleased that we've managed at least to get to this point, which has obviously provided such benefit to the patient. But yes, more on that national and just across the health board. So again, we've got quite close working relationships with our colleagues in the West and within the East. And again, having that more in-depth conversation about being able to partner with those chemists, local chemists in each of the local authorities.
What advice would you give to future Bevan exemplars?
I think it's to tap into all the resources that are available. And there is so much support there, but you just need, it's available. So don't be frightened to literally tap into that and ask for that extra, for, are you able to help me with this? Are you, what about the evaluation? Are you able to point me in the right direction? What other contacts within the health board? Who else should I be engaging with? Because there is so much good ideas out there. And there is so much momentum, I think, actually in Betsy, but sometimes it's difficult to know where to start. And I think that's something that the Commission have really helped guide me through, and make those links. And not to be frightened, say, actually, what, I am working with the Bevan Commission here. Actually, we need to start focusing on this. We need to start moving it. And I would say that it has helped remove some of the blocks, and just having that sounding board. There's such, it's such a resource and knowledge to be able to do that. And so that would probably be my advice. I think if anybody is on this call who's thinking about putting in an application, I'd say go for it. Don't hold back. Honestly, you know, it has been great to be able to do it at this pace of change. I think we could have implemented something like this but I think I would have had a lot more barriers, resistance, and it would have taken longer.
Do you think the shorter time frame of the program and the context of COVID has sped up your process?
I really think it is actually. There is, and that's something that I've reflected and I've actually bringing back into any other projects that I'm managing is having that regular accountability. There is nothing like knowing that in a month's time you're going to be in a networking session and you kind of want to make sure that you've made some progress. And while we're all juggling so many things, and I think that's true across everything, everybody's working really hard, particularly during COVID, that it focuses the mind. And so I think whether it was a month or 2 months, I think it would have been very easy to let other things sort of
Yeah.
take priority, but having that tight time frame, having that actually you're gonna this accountability, I think has really led to people to focus and actually keep that momentum going. So I do think that type of time frame has been quite beneficial. I think if I'd had twice as long, it would have probably taken twice as long to have delivered. And that's been, for me, quite a learning point of thinking about other things that you do, having accountability, making sure that you actually have somebody that you're going to report to help focus that.